may I now ask Pradeep to continue on the topic of neck? May I make you aware that, by the way, there is a Cervical Spine Association which takes 5 days on its congress. So, please go ahead.
Thank you, Prof. Lukele. Good afternoon, fellow delegates. I'd like to share some of my knowledge on neck injury disability assessment. Now, if you go back to ancient times, lawmakers have always tried to compensate individuals who have suffered injury appropriately. If we go back to the ancient laws of Eshnunna, you're looking at about 1,000 to 2,000 years BC, they identified 5 offenses, and one of these deals with bodily injuries. In one of the sections of these laws, a perpetrator was asked to settle the victim a sum of 10 shekels for having inflicted injury. And as we've become civilized, we've moved away from the blood feud to personal injury compensation. Initially, individuals used the Lombard laws where there was specific monetary compensation for various injuries. We've heard excellent talks earlier in the session about how to classify neck injuries, how to assess them and manage them appropriately. And what I would like to share with you is how we assess the physical impairment and the disability that the patient is left with so that we can allow the lawmakers to come up with appropriate compensation. We firstly need to differentiate between impairment and disability. So impairment is the loss of function. For example, somebody has lost power in his legs as a result of a spinal cord injury. Disability is the result of that impairment. So somebody is unable to walk as a result of that impairment. When the functional impairment is severe enough to prevent something like walking, we regard that individual as being disabled. And this is a medical decision. So the pathway is pathology initially that leads to impairment, disability, and handicap. Pathology relates to the underlying disease or diagnosis. The impairment are the physiological consequences as a result of the pathology. The disability relates to the functional consequences, and the handicap are the social or societal consequences of the impairment. And what I will share with you later in the talk is how we go about determining an impairment rating, which is obviously vital so that appropriate compensation can be awarded. What's important is to establish that the pathology is causally related to the event. Now, in the past, when we came up to the park, we often took these game rides with wardens, these game warders, or whatever you call them, guides, and they would point to something under a tree, and all you could see is a belly breathing. And when Nita and I came up early, we took the opportunity of exploring the park on our own, and this was a snap we took between the Fabeni Gate and Skakuza. And it's quite unusual because we recognized there was a problem because there were quite a few vultures in the tree. And when we stopped, there were about 6 cars at this particular site. And we couldn't believe that a leopard could pull down a buffalo. But obviously, you've all seen the devastating effects of the drought, and this buffalo was obviously ill. The leopard usually disembowels the victim, eats the liver and the heart first, and then leaves the rest for other predators. So this is the guides that a lot of you would be using to calculate the impairment rating. And the process is, as is expected, a thorough history, examination. What's important is the individual must have reached maximum medical improvement. In other words, no other further treatment would improve his current status. You need to establish a diagnosis, then use regional grids that I will show you shortly to identify an impairment class. You then apply a grade modifier based on the history examination and clinical findings. You then assign a numerical impairment rating for that particular class and grade, and then finally come up with a whole person impairment, which the lawmakers would use to compensate the victim. So these are the original grids. I don't expect you to read this, but it's clearly mapped out in the book. And it starts off with, the whiplash or soft tissue injury, and ends with a fracture dislocation or complications of surgery. You then use your grade modifier, and this is a simple grade modifier that could be used when the problem isn't a complex one. The functional history, obviously, there could be no problem, or there could be a very severe problem, likewise for physical examination and the clinical studies. There are more complex functional history adjustment tables where you could assign grade modifiers based on whether the patient was asymptomatic or whether the pain was with activity or with sedentary activity. Physical examination, likewise, you could apply these grade modifiers based on your physical findings, whether there were tension signs, compression test positive, reflexes, muscle atrophy, sensory deficit, or motor deficit. Our clinical studies should obviously confirm our clinical findings. So I'll use a couple of case studies to illustrate how one would go about applying an impairment rating. So this is an example of a 42-year-old lady who was involved in a motor vehicle accident, rear-end collision. She was seen in the emergency unit. No obvious physical injury, but she had symptoms. X-ray is normal. She was diagnosed as a whiplash-type injury. She was given a soft collar and advised to see a physiotherapist for local treatment. And at 6-month follow-up, had ongoing neck pain. So if we use the grids, this particular patient would be classified as having a soft tissue injury, fall into class 1. Now you will notice there are quite a few numbers on the top section of this particular grid. So your grade modifiers would be used to either downscale or upscale that percentage. If we look at other parts of the body, for example, the upper limb, this particular percentage is not a whole person impairment. You need to use a grade modifier of 60% for upper limb and 40% for lower limb, as opposed to spine, where these figures relate directly to whole person impairment. So this particular individual with this whiplash type injury had a mild problem. The grade modifier corresponds with the class, so there were no adjustments, and the final whole person impairment is 2%. If we look at this example, 36-year-old male, rugby injury, neck and arm pain, significant neurological fallout related to a disc protrusion at C5-6. Now, I'm not sure why the treating physician elected for conservative measures, but eventually he was subjected to surgery, and as expected, his neurological deficit didn't recover. So if we use the grid, this particular patient falls into this particular category. He has an intervertebral disc herniation, and we have a whole person impairment of 11%, which can then be up or downgraded. If we look at the simplified grade modifier, it's a moderate problem, so there's no adjustment. If we look at the more detailed modifiers, he has pain with normal activity, and the physical examination confirms the ongoing neurological deficit, and our radiological investigations confirm the problem, so there's no adjustment required, and his final whole person impairment is 11%. The last example I'm going to show you is a 57-year-old who was assaulted, motor complete, Asia A, sensory level, no sensory sparing. X-rays were quite unremarkable apart from the soft tissue swelling, and on MRI showed a significant cord lesion with the soft tissue swelling. So this particular patient was subjected to a cervical laminectomy, and there was no neurological recovery. So this particular individual would fall into the severe class, class 4, and you can see your whole person impairment would be 28%. So obviously that's not adequate for somebody who's quadriplegic. So you'd look at other factors. So our grade modifier, there's no adjustment required. But if we look at other particular factors, upper extremity CNS dysfunction, he's lost function in non-dominant and dominant hand. So you need to add the upper extremity CNS dysfunction to that score. Likewise, gait disorder, he cannot stand or walk, and that gives him a whole person impairment of 44%. He's lost bladder and bowel function, and he's lost sexual function. His respiratory system has also been affected, as he's lost intercostal function. He does not have any dysthetic pain. And if we use all these scores, we come up with 153%, which is obviously nonsense. So they've, in the book, included combined charts where you take the highest score on the grid and map that with the second highest score and work your way down. And I'll illustrate that. So that's the particular grid. I'm sure you can't read the figures, but you have all the numbers on each axis, and you then plot the highest number with the second highest number and come up with a combined score. So in this particular example, you had 44% plus 28, you come up with 52. You then add all the other impairment scores, and this particular individual ends up with a whole person impairment of 80%, which is appropriate for somebody who's quadriplegic. I'm sure the narrative test causes a lot of confusion amongst orthopedic surgeons, and essentially all it is an adjustment to the patient's particular circumstances. And it should highlight the differences that the impact would have on an individual depending on his social and geographical circumstances. And this is, someone that we would classically see in the Western Cape with quadriplegia, and he goes back to this sort of environment, and obviously the narrative test should be applied in an individual who scores less than the required 30%. As opposed to Superman, who survived for quite some time despite having a high cord injury. So in summary, I think quantifying physical impairment can allow appropriate compensation. We need to diagnose the pathology, determine the impairment class based on the functional history, physical examination, and objective clinical studies. We would then apply a class and subject that to grade modifiers, allowing us to allocate a final whole person impairment. Thank you.